everyone, welcome to EasyMed. I am Rakesh Pandit. So topic for today is acute kidney injury. Acute kidney injury have been traditionally defined as abrupt loss of kidney function leading to rapid decline in glomerular function rate, that GFR, and there is accumulation of the such as B1, that blood urea nitrogen, and creatinine, and there is a dysregulation of extracellular volume and electrolyte homeostasis. AKI embodies a continuum of the renal dysfunction that runs from the increase in serum creatinine to complete anuric and renal failure. So it affects all age group, and 7% of the hospitalized patient and 20% of acute ill patient developed AKI. In AKI associated with sepsis and multiple organ failure, mortality rate is 50 to 70%. Similarly, in the elderly, it can have the poor prognosis. So, friend, KDIGO, that is Kidney Disease Improving Global Outcome, have classified and given definition of the AKI have having the any of the following feature, that is creatinine increased by greater than or equal to 0.3 milligram per deciliter within 48 hours, and second is that creatinine increases by greater than or equal to 50% above baseline within 7 days, and urine output is less than 0.5 ml per kg per hour for greater than or equal to 6 hours. Similarly, it has also given three stages according to serum creatinine and urine output. Stage 1, it has serum creatinine of 1.5 to 1.9 times from baseline or greater than or equal to 26.5 micromole per liter or greater than or equal to 0.3 milligram per deciliter increase. Similarly, urine output is less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2 have serum creatinine of 2 to 2.9 times baseline and urine output 0.5 ml per kg per hour for greater than 12 hours. Stage 3, there is 3 times baseline serum creatinine or increase in serum creatinine to greater than or equal to 354 micromole per liter or greater than or equal to 4 milligram per deciliter, or initiation of renal replacement therapy, or patient is less than 18 years, or decrease in eGFR to less than 35 ml per minute per 1.73 meter square. Urine output less than 0.3 ml per kg per hour for greater than 24 hours, or anuria for greater than or equal to 12 hours. Friends, it is a schematic representation of the phases of ischemic AKI as described by motorists. The following is the initiating phase, which is characterized by sharp decline in the glomerular filtration rate. This is followed by extension phase, which is during this phase there is a renal insult is propagated and functional decline is further. This phase is characterized by intense ischemic reperfusion injury. After this phase has subsided, there have been maintenance phase for available length of time. Course of ischemic AKI from insult to the first evidence of recovery usually occurs of the 7 to 21 days. There are some term and definition that we'll encounter throughout this lecture. It is exotemia. Exotemia have the life finding of elevated blood urea nitrogen plus creatinine. It is due to decrease in glomerular filtration rate. Similarly, uremia. Uremia means having three constellation of feature, that is exotemia plus clinical sign and symptom plus biochemical abnormalities, and constellation of sign and symptoms that will encounter in uremia or either severe AKI or end-stage chronic kidney disease is nausea or vomiting, anorexia, fatigue, lethargy, and confusion. Perirenal exotemia. There is elevation of serum urea in absence of elevation of creatinine, that is especially due to the poor renal perfusion. Clinical presentation and diagnosis of the patient. Patients generally have the 3 days history of the vomiting and diarrhea most likely has the prerenal AKI caused by volume depletion. Similarly, patient may present such as a 6-year-old child with recent pharyngitis who have present with periorbital edema, hypertension, and gross hematuria. Most likely has intrinsic AKI related to acute post-infectious glomerulonephritis. Similarly, critical ill child with a history of protracted hypotension or exposure to nephrotoxic dose medication, then most likely we suspect that it has ATN, that Equitable necrosis. Similarly, neonate with a history of hydronephrosis seen on prenatal ultrasound studies and palpable bladder, most likely congenital urinary tract obstruction, probably related to posterior urethral valve. So, a physical examination, we must be taught the careful attention to the volume status, tachycardia, dry mucous membrane, and poor peripheral perfusion, suggesting of inadequate circulating volume and possibility of prerenal AKI. Hypertension, peripheral edema, rales, and cardiac gallops suggest volume overload and possibility of intrinsic AKI from glomerulonephritis or equitable necrosis. The presence of rash and arthritis might indicate systemic lupus erythematosus or hinox-swollen purpura nephritis. Flank palpable flank mass may be seen in with renal vein thrombosis, tumor, cystic disease, or urinary tract obstruction. So, guys, the common cause of acute kidney injury have been classified into three types, that is pre-renal, intrinsic renal, and post-renal. Pre-renal AKI is called as pre-renal exotemia. It is characterized by diminished circulating arterial volume, which result in decreased renal perfusion and ultimately decreased glomerular filtration rate. But there is no evidence of the kidney damage in this pre-renal. If the underlying cause of the renal hypoperfusion is reversed promptly, renal function is returned to the normal. If the hypoperfusion is sustained, then it can result in intrinsic renal parenchymal damage can develop. So the common causes are the dehydration, hemorrhage, sepsis, hypoalbuminemia, and cardiac failure. Intrinsic renal. Intrinsic renal is characterized by renal parenchymal damage, and it have been classified into three parts, that is glomerular cause, vascular cause, and tubular cause. Glomerular cause is acute glomerulonephritis, post-streptococcal glomerulonephritis, systemic lupus erythematosus, Good-Pasteur syndrome, anti-glomerular basement membrane disease, and vascular causes like hemolytic uremic syndrome, TTP, that is thrombocytopenic purpura, third malignant hypertension, fourth renal vein thrombosis, and fifth erythroembolic kidney disease. Similarly, tubular cause are sepsis, that toxin can cause tubular necrosis. Similar ischemia, bone and acute pancreatitis can cause massive fluid resuscitation that leads to leaky capillaries. This can cause massive ascites and abdominal compartment syndrome, that is greater than 20 centimeter of water, and renal vein compression and ischemic damage can lead to the AKI. Similarly, there are nephrotoxin which can cause the tubular destruction. They can be defined as exogenous and endogenous. Exogenous is aristotelic acid. It is a cyanic herbal medicine, and aminoglycosides toxicity. It is can damage B2 receptor uh, and amphotericin B, cisplatin, and contrast-induced nephropathy. Similarly, endogenous is hemolysis, that is mismatched blood transfusion, which result in hemolysis, then hemoglobinuria and block the kidney. Similarly, rhabdomyolysis, and third is multiple myeloma, and some crystal which can dislodge on tubules and cause the AKI. Crystals are crystals which are formed during the tubulolysis syndrome, which is mainly the uric acid. And if the person consumes ethylene glycol, it can cause the calcium oxalate crystal deposit on the tubules and which block the kidney and cause the AKI. Similarly, vascular cause renal pain thrombosis. AKI plus unilateral enlarged painful kidney, that is hypernephrosis, has enlarged but not painful kidney. Crush injury in the Plasmodium falciparum malaria in the erythroembolic kidney disease. Now guys, acute tubular necrosis. First, the hypoxic injury and nephrotoxic insult is most common cause of the intrinsic renal in the US, and acute tubular necrosis is prolonged ischemic and hypoxic, ischemic or hypoxic and nephrotoxic insult, which can lead to acute tubular necrosis. It is most often seen in critically ill infant and children. Mechanism leading to ischemia, ischemic AKI include hypertension, intravascular volume depletion, and decreased effective intravascular volume, vasoconstriction or dilatation. There are some drug which can cause like AC inhibitor, angiotensin receptor blocking agent, radio contrast agent, and renal artery obstruction due to the embolus or thrombosis can cause the ischemia, and the which can lead to the acute tubular necrosis. So typical pathological feature in acute tubular necrosis is that there is tubular cell necrosis, but significant histological and histological feature are not constantly seen in the patient with clinical acute tubular necrosis. And then the postrenal causes. Postrenal cause is mainly caused due to obstruction of urinary tract, which include posterior urethral valve, uretropelvic junction obstruction, uretrovesicular junction obstruction, urethroceal tumor, erythrolithiasis, hemorrhagic cystitis, and neurogenic blood. Forget to tell about acute intestinal nephritis and tumor lysis syndrome. First, tumor lysis syndrome. So, tumor lysis syndrome is a specific form of AKI that is related to chemotherapy-induced cell lysis in patient with lymphoproliferative malignancy. It causes tubule obstruction due to uric acid. Acute intestinal nephritis. It is another common cause of AKI and usually result of hypersensitivity reaction due to therapeutic agent and infectious agent. There are certain drug which can cause the AKI. First, the mechanism, the efferent arteriole, and it is efferent arteriole. The efferent arteriole is generally have the low diameter than efferent arteriole, so that there can be infiltration of the fluid. So guys, this is efferent arteriole and it is efferent arteriole. Generally efferent arteriole have the more diameter than the efferent arteriole, so that the infiltration of the urine formation can occur. First, the prostaglandin maintain the blood volume by vasodilating the efferent arteriole. Similarly, angiotensin 2 constrict the efferent arteriole and maintain intraglobullar pressure. But NSDs inhibit the prostaglandin, which result in which do not cause vasodilation, and there is no blood flow. So there can be decrease in GFR. Similarly, ACI inhibitor and ARB inhibitor can cause the efferent arteriole inhibit the angiotensin 2 and that cause the dilatation of the efferent arteriole, and which cause the more blood flow to this area and inhibit the intraglomerular pressure. So guys, the medication that can cause the AKI is inprenal, the diuretics, and which can cause dehydration. Similarly, alteration in the intrarenal autoregulation like AC, ARB, and NSAIDs, calcineurin inhibitor, cyclosporin, and tacrolimus. Similarly, acute tubular necrosis is caused by aminoglycoside, cisplatin, and tenofovir. And AIN, acute intestinal nephritis, is caused by beta-lactam, vancomycin, sulfomethoxazole, trimethoprim, and NSAIDs. Similarly, the crystal nephropathy is caused by the acyclovir, ganciclovir, ciprofloxacin, sulfomethoxazole, and methotrexate. Post-retinal cause is caused by decreased bladder sensation and decreased impaired digital contraction and engaged urinary sphincter tone. This mechanism is hampered by the opioid. Similarly, sympathomimetic like nasal decongestant, any drug with anticholinergic effect like antihistamine, tricyclic antidepressant, SSRI. How can we diagnose in laboratory? The most common finding can see is anemia, and anemia is usually due to dilutional or hemolytic or and in SLE, hemolytic SLE, and renal vein thrombosis may be cause of the anemia, and hemolytic uremic syndrome. So all can cause the decreased hemoglobin level. It can be seen in the blood examination. Similarly, leukopenia, that is decreased leukocyte, can be seen in SLE and sepsis, and decreased platelet can be seen in the SLE, renal vein thrombosis, sepsis, and hemolytic uremic syndrome. Similarly, decreased sodium due to dilutional and metabolic acidosis can be seen in the blood profile, like increase in the hydrogen ion or the increase in the carbon dioxide concentration can be seen. Similarly, the elevated serum concentration of the blood, nitrogen, creatinine, uric acid, potassium, phosphate, and hypokalemia can be seen. Similarly, the serum finding like C3 levels may be depressed in the PSGN and SLE or the membranoproliferative glomerulonephritis. Similarly, antibodies can be detected in the PSGN, in neutrophils, cytoplasmic, microscopic polyarthritis, glomerular basement membrane disease, that goes Pastors disease. The presence of hematuria, proteinuria, and red blood cell or granular cast suggests intrinsic AKI, in particular glomerular disease and equitable necrosis. The presence of white blood cell cast, white blood cell or white blood cell cast with a low-grade hematuria and proteinuria suggests tubulointerstitial disease. The laboratory finding, according to the disease, what you can see is in hypovolemia, there the sediment can be bland, protein is none or low, urine sodium milliequivalent is less than 20, normal is less than 20, and the urine osmolality is greater than 400. Guys, urine osmolality can vary from 50 to 1200, but 1200 is in extreme cases like not drinking water, maybe person be in desert condition, but this is normally not present. But if present in normal condition, normal environment, then it can be considered pathological. Fractional excretion of the sodium is less than 1%. Acute tubular necrosis, brownish, and the granular cast can be seen in the sediment. The protein can be low or cannot be found. Urine sodium milliequivalent is greater than 30, and urine osmolality in milliosmol per kg is less than 350. Similarly, fractional excretion of the sodium in percentage is greater than 1%. In acute intestinal nephritis, white blood cell, eosinophil, cellular cast can be seen in sediment, minimal but may be increased with NSAIDs. Urine sodium milliequivalent is greater than 30 and osmolality less than 350. Fractional excretion of sodium varies. Glomerulonephritis, red blood cell and red blood cell cast in found in the sediment, increased protein, and it is less than 20 urine sodium and greater than 400 urine osmolality, less than 1 fractional excretion of sodium percentage can be found. Similarly, in obstruction, there will be blunt or bloody segment, the protein will be low and less urine sodium, but in few days can be increased up to greater than 40. Urine osmolality less than 350. Similarly, fractional excretion of the sodium less than 1 in acute and greater than 1 in the few days. Injury, there you can see the haziness, and cardiopanic angle is also that much not appreciable. So the appearance is indistinguishable from left ventricular failure, but heart side is usually normal. Plot management of AKI. Kidney injury, first we have to assess the fluid status, as This will determine the fluid prescription. If the hypovolemic, then optimize the systemic hemodynamic status with fluid challenge and inotropic drug if necessary. Once euvolemic, match the fluid intake to the urine output plus the additional 500 ml to cover the sensible loss. If the fluid is overloaded, prescribed diuretic with a loop diuretic at highest dose will be often required. If the response is unsatisfactory, dialysis may be required. Similarly, if the administration of the calcium resonium to stabilize the myocardium and glucose and insulin to correct the hyperkalemia. If it often greater than 6.5 millimole per liter, then we have to correct it as a holding measures until the definite method of removing the potassium is achieved, dialysing or restoring the renal function. Consider the administrating sodium bicarbonate 100 millimole to correct the acidosis if the hydrogen is greater than 100 nanomole per liter, that is pH is less than 7. Discontinue the potentially nephrotoxic drugs and reduce the dosage of therapeutic drug according to level of renal function. Similarly, ensure the adequate nutritional support and consider the proton pump inhibitor to reduce the risk of upper GI bleeding. Screen the intercurrent infection and treat promptly present. In case of urinary tract obstruction, drain the lower upper urinary tract necessary. So guys, this is overview of the management of acute kidney injury, but you can go detail in the management of each symptoms, like how can you manage the hypertension. So guys, first hyponatremia. So hyponatremia is most common dilational disturbances that is most corrected by fluid restriction rather than sodium chloride administration. So administration of hypertonic 3% saline should be limited to the patient with symptomatic hyponatremia, that is seizure, lethargy, or those with the level of the sodium less than 120 milliequivalent per liter. And acute correction of serum sodium to 125 milliequivalent per liter should be accomplished using the following formula. The milliequivalent of sodium required is 0.6 into weight of kg into 125 minus serum sodium in milliequivalent per liter. So AKI patient are prescribed to GI bleeding because predisposed to GI bleeding because of uremic platelet dysfunction, increasing stress, heparin exposure. If treated with hemodialysis or the continuous renal replacement therapy. Oral or intravenous hydrogen blockers such as ranitidine are commonly administered to prevent this complication. And hypokalemia is primarily treated with lowering the serum phosphorus level. Calcium should not be given intravenously except in tetany. This is very important point, guys. To avoid the deposition of calcium salt in tissue, patients should be instructed to follow the low phosphorus diet, and phosphate binders should be only administered to bind with the ingested phosphate and increase the GI phosphate excretion. Common agents include Sibyl-Mer, that is renal gel, and calcium carbonate, and calcium acetate, that is phosphol low, and aluminum based binder commonly employed in the past and should not be used now because of the risk of the aluminum toxicity. Now the hyperkalemia management. In AKI, rapid development of hyperkalemia is a serum potassium level greater than 6 milliequivalent can lead to the cardiac arrest and death. So the earliest echocardiogenic changes is a peak T wave, and then there will be widening of QRS interval, which optimally lead to ST segment depression and cause the ventricular arrhythmia and cardiac arrest, and may cause death. The sodium polystyrene sulfonate resin, that is 1 gram per kg, should be given orally by the retention enema. This resin exchanges sodium for the potassium and can take several hours to take the effect. As you can give the calcium gluconate 10%, 100 milligram per kg IV over 3 to 5 minutes. Sodium bicarbonate 1 to 2 milliequivalent per kg IV over 5 to 10 minutes can be given. But along with the sodium bicarbonate, regular insulin can be given 0.1 unit per kg. Glucose have to give in 50% solution because that can cause the hypoglycemia. and glucose solution 1 ml per kg over the 1 hour. And the mild metabolic acidosis is common in AKI because of retention of hydrogen and phosphate and the sulfate, but rarely require the treatment. If acidosis is severe, that is less than 7.15, the serum bicarbonate is less than 8 millicovalent per liter. To contribute to significant hyperkalemia, treatment is indicated. Acidosis should be corrected partially by intravenous route, generally giving the enough bicarbonate to raise the arterial pH up to 7.2, which approximates the serum bicarbonate level 12 millivalent per liter. The remainder correction may be accomplished by oral administration of sodium bicarbonate and after normalizing the serum calcium and phosphorus level. Hypertension can be from hyponatremia associated with the primary disease process, and expansion of extracellular fluid volume is the most common in AKI, that's into acute glomerular nephritis or AGS. Water restriction is critical, so and diuretic administration may be useful in such patient. Is Radipin, maximum of 5 milligram 4 times a day, may be administered for relatively rapid reduction in blood pressure. Similarly, long-acting agents such as calcium channel blocker, amlodipine, beta blocker, propanol, point. Similarly, left load can be helping management control the blood pressure. Children with severe symptomatic hypertension, hypertensive emergency or urgency should be treated with a continuous infusion of nicardipine, 0.5 to 5 microgram per kg per minute, and sodium nitroprusside 0.5 to 10 microgram per kg per minute, labetalol 0.25 to 3 milligram per kg per hour. Similarly, esmolol 15 to 300 microgram per kg per minute and can be converted to intermittently dosed in antihypertensive when more stable. Neurogenic symptoms in AKI include headache, seizure, lethargy, confusion, encephalopathy. Potential etiologic factors include hypertensive encephalopathy and postnatremia, hyperkalemia, and cerebral hemorrhage, cerebral vasculitis, and uremic state. Benzodiazepine are the most effective agent in acutely controlling the seizure, and subsequent therapy should be directed toward a precipitating goal. Similarly, anemia in AKI is generally mild, that is hemoglobin 9 to 10 gram per deciliter, primarily result from the volume expansion, that is hemodilution. Children with HES, SLE, active bleeding, prolonged AKI can require the transfusion back to red blood cell if their hemoglobin level is fall below the 7 gram per deciliter. So that's it, guys. Thank you for watching the video.